One, please start, sir. We are live.
Okay, good evening, friends. Welcome to the 91st webinar of the PG Track program of Delhi CSI. And we are going to continue with our series of learning with spotters. And after the first session, today we are with Dr. Girish. Today we have our dear friend, Dr. Kamal Sharma. And he'll be projecting certain interesting spotters, and it's just a learning exercise. So let me tell you, take an initiative, raise your hands, or Dr. Girish, my colleague, will be identifying one of the persons, and you can easily interpret these spotters, give your answers. It doesn't matter whether it is right or wrong. Most important is participation. Just enjoy this session. And Kamal, I really thank you and welcome you for this unique activity. You're always so kind to help us and teach our residents with your vast ocean-like knowledge, and you pour some little droplets. And my dear colleague Girish and Nitish and Sumod, thank you so much for joining. So over to you, Kamal, to start this session, please. Dr. Girish.
Good evening. Thank
please
you,
don't
Dr.
answer without your turn. Yeah.
Good evening. Thank you, Dr. Mohit. Thank you for the opportunity. I think I'm just going to be sharing a couple of slides. I have identified 20 spotters. Some of these you might have seen or heard somewhere else, but I'm sure I'm going to grill you on something beyond what you can identify, because in the exams and even otherwise, it's not just identifying what you have picked up, but also to know what you will end up doing for them. So I hope my screen is visible, and I'll be sharing the spotters. So you're going to take a shot at these spotters, all the fellow students, and those who have joined us today online, they can try their guess as well for the spotters. So this is spot one, and I open the forum for everyone. This is an ECG. I want somebody to go ahead and read it and start interpreting it. Anyone willing to take that? Any volunteers?
Yes, sir. Sir, should I start?
Yes. Yeah, please go ahead.
Yes, sir, 12 lead ECG showing a broad complex tachycardia with irregular heart rate. So most probable DD would be, sir, AF with pre-excitation.
Okay, so diagnosis, yes, you got it right. But point is, whenever you are asked to speak a spotter, the commonest things that a resident misses out on reading out is rate and axis. So don't miss out on your rate and axis whenever you're interpreting anything. So rate, maybe, for example, you may not be too keen to pick it up, but can you tell me how would you pick the rate here in this kind of an ECG, Imran?
Sir, Sunil sir here, sir. Sir, we'll take.
Sunil.
Yes, sir. 30 large boxes. We will count the RR interval. And
okay.
Multiply by 10, sir.
So how will you count the boxes here?
Sir,
can you count it them? Can you count them here?
Yes, sir. Yes, sir. Definitely, sir.
So how long will you take if you have to count? Remember, a simple method to interpret is when you're looking at a rhythm strip, rhythm volt, which is V1 here, the rhythm strip here would actually be nothing but short of 10 seconds. So in most of these 12 lead single display with a rhythm strip available at the bottom would actually amount to the whole itself, the plate itself representing 10 seconds. All you need to do is just multiply the number of RR intervals here, and you will get the heart rate. So that's pretty easy. You don't even have to count the boxes. Am I clear?
Yes, sir. Yes, sir.
Sunil? So you just have to count number of RR. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, and 33. 33 multiplied by 6 is your heart rate here. So that's very easy to do rather than find out where are the 30 boxes. These kind of strips, which are inclusive of 12 of this rhythm strip with the 12 lead ECG, are automated to give you the rhythm strip of 10 seconds. So what you're getting is simply multiply the RR by the number of RR, multiplied by 6, and you'll get the heart rate. How would you get that for the axis in this patient?
Sir, one and...
So what is the axis of this arrhythmia?
Sir, we can simply see at the 1 and the AVF, sir. So 1 is positive and AVF is negative. So it's a left axis deviation.
So again, a very bad methodology, I would say, Sunil, to do that for a DM level exit exams. Most of my colleagues will agree that at DM, you would not be happy enough to understand left or right axis. You would be more interested in getting the exact value of the QRS axis. For that, you'll have to go by your
Sir, we'll
equiphasic approach. Correct, Sunil. So can you do that, the equiphasic approach? What is that?
sir, here lead 3 looks equiphasic, sir.
Lead 3 is not equiphasic. Lead 3 is negative. Lead 3 से तो lead 2 का voltage कम है. Either the voltages are as good as 0 or you have as much positive as much as negative. So which lead is that?
Sir, here lead 2, sir.
Lead AVR?
No, Sunil.
Think about AVR.
Again, negative है ना?
2 is negative, 3 is negative, but AVR?
AVR is equiphasic, sir, here.
Correct. So AVR, if it is equiphasic, so what is the axis of AVR normally?
Sir, AVR plus 30 degrees, sir.
AVR is plus 30.
Yes, sir.
Plus 30 degree. The negative end of AVR is plus 30 or positive end of AVR is plus 30. So 1 degree plus 30 would be what? 0, 60.
Yes, sir. Normal.
So 0, 60, 120. 0 is lead 1, lead 2 is 60, lead 3 is 120, AVF is 90. AVL is minus 30, AVR is 210. The negative end of it is on the plus 30 side. So the tail of the AVR is on by plus 30. So the lead is the axis is perpendicular to plus 30. So either it is you add 30 to it or you subtract 30 to it. So when you add 30 to it, it will become 120. For that to happen, you'll find the lead which is perpendicular to AVR. So which lead is perpendicular to AVR? That is lead?
Sir, it will be lead 3. Sorry.
3, correct. Lead 3 is 120 degree. AVR is 210 degree.
Yes,
so lead 3, you will look at whether it's positive or negative. So lead 3 is positive or negative?
Lead 3 is negative here, sir.
Negative means you have to go away towards. So the axis is tail end of lead 3. Where what would that be?
Minus 90 degree approx.
Minus 90.
Lead 3 AVF. No, sir. No, sir. 1, 2, 3. Minus 60 degree approx.
Tail end of AVF. So yes, correct. So you have 30 say minus 60. You go to minus 60 degrees. So where is the axis now? So that's the problem. When you look at just one in AVF, you actually end up. So this is a no man's land, right? This is the extreme left axis deviation. And that's why you need to actually be telling. Now, why this is not, why would you say this is AFib with pre-excitation? How
Sir,
did you arrive at that? Only irregularity?
No, sir. There is also intrinsic wide deflection is much more. And there is pre-excitation is also there, sir.
Doesn't that go, doesn't the,
the question is, why not AF with RBBB?
Yes, sir. AF with RBBB is there.
So how do you differentiate right bundle branch block in this situation with a pre-excitation? That is the question.
What is
the other name for this tachycardia?
Yes. Asman phenomena?
Yes, sir.
What is that?
Sir, long short, long cycle, there will be...
What? No, long short nahi. What follows what? Short follows long, long follows short. And what is the conduction and how, as Professor Greaves was saying, is to look at what pattern.
Sir,
he's already given you a clue.
Long follows short, sir, then there will be the RBBB pattern.
When a long follows short, there'll be
RBBB pattern due to large refractory period of right ventral branch.
So why is it always when a long follows short, or why would you get it then?
Because of the refractory.
Or is it short follows long? The refractory period of the subsequent cycle is proportionate to the what? To the duration of previous QRS. So the right bundle would not have recovered if the previous cycle was long. And hence, when a short cycle comes after a long cycle, it will conduct with aberrancy. Am I clear? When a long cycle, so there is a long cycle, which means the cycle was long, it means the refractory period for the subsequent cycle should be long. But when a short cycle comes in that long period, after a long period, the right bundle would not have still recovered because the refractory period of the right bundle is longer than that of the left. If it was coming too early, it will not conduct it as at all, because the left and the right both have not recovered. But when the right bundle has not yet recovered, because intrinsically the right bundle has got a longer refractory period compared to the right, to the left has recovered, the conduction would happen now with RBBB, and that morphology is called as Asman's phenomena. So it's when a short follows a long, when a long cycle has taken place, then comes a short cycle, it will conduct with an RBBB. That is Asman's phenomena. But as very well Professor Girish has mentioned and shown it to you, that here you can see the RBBB all throughout. Long, short, irrespective, you're getting it. But what about AVL? What are you seeing the last two QRS complexes? Intrinsic wide deflection, is it wide or narrow here?
Intrinsic wide deflection is wide, sir.
Wide. So if it is wide, does it fall actually into the criteria of VT or not?
Sir, maybe, sir. But
yeah, so it falls. So that doesn't hold true here. One reason is irregularity. Second is the Asman's phenomena. One more reason you have to give me why this is. So is there any rough rule, though it's proven otherwise now wrong, is the duration of QRS complexes? How wide the QRSs are usually in favor of a AFib with pre-excitation rather than VT. Is there any cutoff? Can VTs be
140, sir?
No, 140 you can always get. 140 the VTs you can get. No, 140 nahi hota VT. VTs you can 180 and above. So it was roughly said that if you are the QRSs, if you can get during the aberrance, during the tachycardia more than 180, you can assume that they are probably because of WPW, but they have not been. They've been prospectively not been proven, because you can have conductions, you can have VTs coming from a very distant pathway. So the closer a VT is to the septum, narrow is the QRS. If you have a VT coming from an aneurysmally dilated LV and it's coming from the LV free wall, again you can still get a morphology which is very wide QRS. Okay, so previously it was believed in a structurally normal heart. If you know the echoes, in a structurally otherwise normal heart, if you find a bizarre tachycardia AF with WPW, would show QRSs more than 180, which would not happen otherwise in a structurally normal heart. So this was one of the other methodology that people used to talk about. How do you treat it now, Sunil?
Sir, treatment of choice is cardioversion and a medical cardioversion.
Why? Can you use IV amiodarone in this patient?
No, sir, definitely not, sir.
Why not?
Sir, because that amiodarone will block the AV node and it will enhance the conduction through the accessory pathway, so it can convert into VTVF, sir.
Correct. So it can fibrillate. Patient can actually fibrillate. So then why do you give it? What are the drugs that you actually give in WPW for prophylaxis?
Class 1A drug, sir, which will
Only
block.
1A?
Sir, procainamide.
No, not in emergency. I'm asking you prophylaxis. One is treatment, IV treatment, will come to that as well. And what is the treatment in prophylaxis? When you have a patient of WPW, what are the drugs that you give prophylaxis? And let me add one more question. How does that drug act? Again, this is very common. It acts only through the accessory pathway, or it acts only through the conduction system or AV node, or it acts on the both of them. So you categorize drugs accordingly.
Sir, during tachycardia, we have to...
Not during tachycardia. I'm asking without tachycardia. And then during tachycardia, we'll ask.
Without tachycardia, sir, we can target both pathway. So along with flecainide, we can add beta blocker. So
which group of drugs act only on accessory pathway? Which group of drugs only act on the conduction system? Which group of drugs act on both?
Class...
There's a commonly given small table in the chapter of WPW and Brunwald's.
Sir, class 1A mainly acts on accessory pathway. Class
1A and
1A and ibutylide. We can also add ibutylide. So ibutylide also acts on accessory pathway, but it also acts on AV node, sir.
Correct. So both. So class 3 acts on both.
Yes, sir. Class 4 only acts on AV node.
Correct. And class 2 also acts only on the AV node. Beta blockers will also act there only. Right. Yes. So 2 and 4 only on the AV node. Can you use 1B? Can you use 1C? Will 1B work?
1B, sir, can work, sir.
No, it won't. Why? 1B doesn't work.
No, sir.
1B doesn't work.
1C, we can.
1A and 1C can work. Yes. So 1C, 1A and 1C can work. Imran has mentioned that in the chat box. That's correct. 1A, 1C will work on the accessory pathway, not the 1B. 3 will act on both, and 2 and 4 will act only on the AV node. That's how you remember. Now come to tachycardia. What about tachycardia? Drug of choice?
Procainamide, sir.
Correct. So it's the primary agent to the control in AFib in a stable patient. But again, the therapy of choice is defibrillation, as you very correctly mentioned. Dose dash 20 to 30 until dysarrhythmia is terminated. Or if you're getting hypotension, again, you need to stop. Or if the QRS starts getting widened, 50% or more. Or if there is acceleration. Why would you get acceleration? Why would procainamide cause acceleration of the tachycardia? Can procainamide cause acceleration? Again, because we discussed, it blocks what?
It blocks the accessory pathway.
So, how would the tachycardia accelerate? So, there are various wavelets in AFib. What are wavelets? What do you mean by wavelets? In AVNRT, AVRT, the wave fronts are not called wavelets. In atrial fibrillation and flutter, they are called as wavelets because these are small circuitry, short-acting, small, diffuse, erratic electrical currents. And these, some of them, the atria is fibrillating at say 300, 500, 400, 300. You're trying to block the accessory pathway. That will, of course, be blocked, but the wavelet term would still actually can find some more conduction happening through the AV node, which is not blocked. So previously, in older times, it was believed that you should not give these drugs without blocking the AV node completely, especially in patients when you're trying to cardiovert in the pre-amiodarone era. They used to say, always give quinidine in a digitalized heart. You know, you would block the AV node first with digitalis and then give quinidine in the older days when these other drugs were not available before amiodarone came into the front. So in our days, in our MBBS days, we were taught then quinidine-like drugs, which can actually cause paradoxical tachycardia, should always be given after blocking the AV node with digitalization. So the patients who are treated with procainamide should be placed on continuous monitoring because of hypotension, which is a side effect, and as a relative slow onset action and may not reach therapeutic level for almost 7 hours. And that's the reason that people don't actually make this drug of first choice. The therapy of choice, the therapy is, of course, DC cardioversion. Let's go to the next spotter. Now,
I think Dipanjan can answer this.
yes, Dipanjan?
Try to volunteer.
So we will, again, Dipanjan, take the same way. Two things you have to mention. Yeah, sorry, please go ahead.
It's a wide complex regular tachycardia with a heart rate of around.
When do you call a tachycardia to be regular or irregular? What's definition or value for regularity or irregularity?
The RR interval is fixed in this case, sir.
No. So there has to be some cutoff value, no, some numbers. You say statistically significant means p-value less than 0.5. If you say irregular, there has to be some value somewhere. What value would determine it's irregular?
Yes,
what was that?
Value, sir,
you don't know? Come on.
No, sir.
Anyone? When do you call by definition, arrhythmia is irregular only if the longest RR to the shortest RR interval is more than, the funny number is 3 in all measurements in ECGs. 3 small squares, which is 120 milliseconds. Okay. The longest RR and the shortest. Why I said the funny number is 3? 3 is P wave. P wave 3 small square, 3 small square wide. 3 is a lot of times. Again, if you look at the normal PR interval, 3. Again, QRS width, 3, 120 milliseconds. So you call that bundle branch block to be complete, So 3 is the funny number you remember everywhere. That's what you get. That's easy way of that's how I teach undergraduates. That's how you remember. If you don't remember anything. So longest RR, shortest RR, difference should be more than 120 milliseconds, which is not here. That's why you call it regular. Agreed. So what is the axis?
So the axis is the left axis.
No,
Lead 1 is
again, I
positive,
mean,
AVL is positive.
absolutely not. I
AVF
always get turned off. You just talk of axis like this. You have to give me a value.
So the axis is around minus 40 degrees.
Okay. And why do you say that? You're right. It's minus 30 because lead 2 is equiphasic,
Yes, sir.
which is 60
Lead 2
degree.
is
So it has to be
degrees.
perpendicular. Lead 1 is positive. So it will be 90 degree minus kar denge. 60 mein se, you'll get minus 30. 1 is positive. So you're right. It is not 60 plus 90, but it is 60 minus 90. So you're getting minus 30. Correct.
Yes, sir. And we have got negative QRS in lead 3 and AVF and in AVR.
Okay.
And in the precordial leads, we have in V1 it is nearly equiphasic. There's no R or D S wave. And
so diagnosis
from V2 to V6 we have got a positive concordance.
Okay. So diagnosis.
So yes, sir. It is most likely ventricular tachycardia, sir.
Right.
VT.
Again, so ventricular tachycardia, that's correct. More precise at a DM level, you would be expected to tell me from where it is coming, whether it's close to septum, away from the septum, left side or the outside, right side, whether it's outlet or inlet, so free wall or so that those things you can easily make out. How do you make out that?
Sir, if it is outlet, then the 2-3 AVF will be positive. And if it is here the lead 1 and AVL are positive. So it is coming from the right side of the heart.
So you just look at, correct, you just look at V1. So V1 and you look at inferior leads. So inferior leads are negative, which means it's going away from the inferior lead. So it's surely not coming from the outflow tracks, right?
Outflow tracks.
V1 is negative, not positive. Correct. And it's white, so it's not close to the septum. So these are very primitive things. And then again, you can look at the supravalvar and infravalvar, outflow tract and inflow tract. And what else you can see? Can you see the AV dissociation?
Yes, sir.
Lead 2?
Lead 2, it is, sir.
Yes. And even in AVF, you can see. Even in AVF, So this is most pathognomonic, right? You have concordance, you have axis. But the most important thing that can diagnose a VT from a SVT with aberrancy is going to be AV dissociation. If you can find AV dissociation, fusion beat, capture beat, then you've done it. These are most pathognomonic features because fusion and capture would never happen with an SVT with aberrancy, right? So this is a ventricular tachycardia, and these are the criteria we know of. Brugada criteria, Veracay criteria, algorithm. So these are the two important. Can anyone tell me the third algorithm? There are 3 mentioned in Brunwald. Third one?
AVR criteria.
Okay, but the name, there's a name to it. Brugada criteria, Veracay criteria, Milan criteria, Imran is writing. So Brugada we all know, absence of QRS in all precordial. Then look at the R2 which is more than 100 AR, which is again a VT. AV dissociation, which again is a VT, and then you go by the definitions. Miller's criteria, that's correct, Imran. So you were wrong on Milan. It's a typo, I believe. So Veracay criteria is again AV dissociation you look at first. This is what we classically learned. So that is Veracay. So if you look at AVD and it's present, it's done it. Initial R in the AVR present, then again it's a VT. You look at the QRS morphology, which is unlike bundle branch blocks, again a VT, and you have the intrinsicoid VI upon VT less than 1. If then again it's a VT. Right. So this is what it means. If you're looking at the initial, these are some cutoff values: 30 milliseconds, 70 milliseconds, and the notching and the slur. So if you can find V1 or V2 like this, you're dealing surely with a VT. This is 30, this is 70, and the downstroke is slurred. Here you can see some of them actually getting fulfilled in these patients. So this is like here, you can see it's more than 70 for sure. And you can see AV dissociation, which I discussed. So those are some of the findings that you have. And so basically, when you're looking at a VT, morphologic VT in a structurally normal heart, either it's a LBPP pattern with inferior axis where it is called as an RVOT VT, which would help, as I mentioned it already to you, The LBBB pattern would mean it's coming from the right side. And if it's a positive 2,3 AVF, which means it's a RVOTVT. If it's coming from S1, if you find S waves in the L1 and R wave transition in V1 to V2, and S wave is present in V5 or V6, then it is an infravalvular. If you can find S wave which is absent, then it is supravalvular. So based on the RVOTs, on the LVOT, you can decide from the pattern, as I said, LBBB versus S wave in L1 or R wave V1 to V2. And again, you can look at the S waves in V5, V6, which can be help you in differentiating supravalvular versus infravalvular LVOT. Again, RBBB left axis is, of course, posterior fascicular exit, and RBBB with the right axis would be anterior fascicular exit, which is the ILVT as we call them. So none of them is sensitive. Only sensitive to beta blockers are idiopathic polymorphic VTs, which are beta blocker sensitive, which we very well know of. So again, these here will be a narrow complex tachycardia, RBBB with left axis and LBBB a right axis with short QRS complex, narrow QRS VTs. So these are the fascicular VTs, and the broad complexes are coming from the outflow tract. So these are some of the classical VTs which you should be able to pick it up. Anyone else now on spotter 3? Any volunteers?
I think we can go one by one. I think Akhilesh can attempt this.
This is very easy. Anyone? Any volunteers? Let me try to help you. Look at any ECG. Look at the P waves. Are the P waves there? Yes. So the principle of ECG is Church's law P, as they call it in Marriott's book of electrocardiography. You mind your P's. Church's law P is the mind your P's. Find where the P's are. The P's are fine. They are doing good. What is happening is the QRS. What is happening to QRS?
Sir, should I try?
Yes, go ahead, please, Sunil.
Sir, 12 bleed ECG showing the normal sinus rhythm with heart rate of not normal sinus rhythm with heart rate of more than 100, around 110, 120. Axis, sir, AVL is equiphagic. So the axis will be AVL positive will be lead.
AVL is equiphasic, so and VD2 is positive, so axis is
60 degrees, sir.
60 degrees. Simple. So वैसा दो बार, you just have to practice this. There's no big, you can easily pick up the leads. Just keep practicing in couple of ECGs the axis, and you do it instantaneously. Correct, 60 degree. So that's fine. What's the problem? Imran has already answered. What is it?
QRS alternance is there.
Electrical alternance. So what are the causes?
Cardiac tamponade, sir.
Pericardial effusion, large pericardial effusion with cardiac suspected tamponade. Now remember, that's the MD level question.
Yes, sir.
Now what becomes the DM level question? So tell me other causes where you get alternance, electrical alternance. So what are the different types of electrical alternance? You have QRS alternance, you have T alternance, and then you have PQRST alternance. And you can even have P alternance. So do you know causes for them?
The T alternance mostly seen in arrhythmia like
Which arrhythmia?
long QT syndrome, sir.
Absolutely good, fantastic. So T wave alternance is a feature of long QT syndrome. Can you be more precise? Which